Why palliative care in ALS? The appropriateness of a care model for managing complexity. This year, 2023, ALS celebrates its 40th anniversary. We began in 1983. Until today, we've grown up. We have 64 territorial sections spread in 19 Italian regions. We did training throughout Italy. As you can see in the table, 406 training modules have been developed by us since 2009 for a total number of participants of 9,299. We published papers to help healthcare professionals, citizens, and patients. These regard the therapeutic choices of the person affected by ALS, the person affected by ALS and palliative sedations, one document on the Law 219 about the rules of informed consent and advanced planning care, and two position papers, one on the person with ALS and the revocation of informed consent under the Law 219, and the other one is on the person with ALS in emergency department. As said before, ALS this year celebrates its 40 years by organizing a series of conferences, a real roadmap in 5 Italian cities with the aim of making known the palliative care in ALS, bioethic topics, and possible organizational health care model aimed at the care of the person affected by ALS. In this picture, you can see the posters of all the events. ALS work is explained in this document. The title is Why Palliative Care in ALS, the Appropriateness of a Care Model for Managing Complexity. We think that the person with ALS must be taken over by palliative care from the time of the diagnosis. 20% of ALS centers include palliative care specialists, and palliative care specialists, usually at an advanced stage, are introduced to patients and their families during treatment paths by the same ALS specialists. The crucial issue is that of integrating palliative care from the very beginning, that is to say, from the diagnosis. WHO definition of palliative care is quite well known. It's an approach that improves the quality of life of patients and their families who faces problems associated with life-threatening disease throughout prevention and relief of suffering. What does palliative care offer? They can offer short-term treatment for symptoms management, home support, physiotherapy, occupational therapy, spiritual and religious support, complementary therapies, daytime palliative services, family care, counseling, medical offices, and so on. The person affected by ALS has continuous requests because the disease causes him and his family many changes. For instance, in walking, in the ability to look after his body, in the strength of his voice, and in the difficulty to breathe and cough, until the complete withdrawal of the autonomous capacity to carry out these actions. Specialist palliative care deals with all these continuous and destructive changes. They accompany the sick people and their families in the serious losses so that they can be free to choose. But what does to be free to choose mean? It means that the patient must be able to decide which proposal, for example, for nutrition and breathing and communication, is suitable without having symptoms that disturb and distress. The patient must be sure to have a competent team with which can elaborate his choice in appropriate time for decisions after a complete and personalized communication. And that means that the person affected by ALS must be supported by a specialized palliative care team that is able to describe all the therapeutic possibilities for the acceptance or not acceptance of any therapeutic proposal involving the family and other involved people in all the steps of communication and choices. The specialist palliative care team must be able to integrate with the other specialists and with the other multidisciplinary team in order to act harmoniously. However, people with ALS can manifest conditions such as frontotemporal dementia or behavioral disorders. It is therefore necessary to document the goals and the treatment preferences of the person with ALS before an acute problem occurs, especially if respiratory, in order to anticipate future disabilities. Understanding the complexity of the care needs for the person with ALS makes it possible to distinguish between patients with the need of specialized palliative care from those who can be managed by general or primary palliative care. The process of assessing patient complexity can facilitate the analysis of the patient and his needs, the care preferences of families, and contribute to the shared decision-making process. In Italy, the protection of the person with ALS is implemented according to the principle of self-determination ratified by Law 219, allowing them to know and decide, not only in the here and now, but for day tomorrow and the day after tomorrow. This is the APC, which in Italy is defined as Shared Planning of Care, PCC, Article 5 of the law. The specific indication of the law provides for sharing a care planning which involves a true relationship between the person with ALS and the doctor in order to face a complex and articulated path. Treatment models of ALS must protect the person despite the poor prognosis and not modifiable clinic history due to the lack of effective therapies, except for instrumental support choices. In Italy, palliative care are regulated by Law 38 and are implemented in 4 settings: outpatient clinics, day hospice, home, residence or hospice, and hospital consultancy. The standard model of home care shows challenging limits, as the person affected by ALS and caregiver have access to neurological, physiatric, nutritional, respiratory, and psychological assessment and treatment skills, but they do not have enough space to address prospective support conditions such as treatment withdrawal, treatment waiver, and palliative sedation. The value of the integration of palliative care is also supported in the outpatient model, in which specialist palliative care can support other specialist care. The perspective of family members is that the family members are significantly more likely to know the patient's treatment preferences after early planning of care was completed with the patient, and they have a lower decision burden when they are aware of the patient preferences. I thank you very much.
Thank you so much. We do have some questions here.
Good morning
Kathy?
to everybody.
Yep.
Hi. Thank you. That was a great presentation. And my question is, sometimes when something's embedded in law and something is in practice, there's a little bit of a gap between the law and the practice. And I would just like your opinion on how well that gray area is navigated in your jurisdiction.
Yes, sometimes it's difficult to coincide the law and the clinical practice. We try to avoid that gap, trying to build with the family and the patient personalized steps of care, and try to include some medical in-law doctors that help us to reduce this gap. For instance, there's a problem with the dementia because they cannot choose. So the law just said to protect them. And protect them means that we have to talk a lot with the families to build the biography of this patient, which is a practical bioethical problem, because if one citizen is affected by ALS and dementia cannot choose, it's the healthcare team that must choose for him. And this is a really important gap that we try to reduce, talking with the family and try to build the story of the patient with them.
Yes, absolutely. Are there any other questions? Anything online? I think, adding another dimension to any clinics, adding this extra, the palliative care, I think adding extra care to people can be absolutely helpful. Definitely.
Thanks a lot.
Thank you so much.
You're welcome.